Assalamu alaikum. We'll talk today about Kawasaki disease in children. First of all, definition: Kawasaki disease is an acute self-limited febrile illness caused predominantly affecting children below 5 years old. So it is an acute self-limited febrile illness, and it occurs predominantly in young children below 5 years old. So it is self-limited, like rheumatic fever. It will improve by itself, even if we don't give the patient IVIG. Almost it will improve. Why we talk today about Kawasaki? Because the major concern about Kawasaki is its complication on the coronary artery with aneurysmal formation and may cause thrombosis and thrombosis and may cause stenosis of the coronary artery and myocardial infarction. So the problem in Kawasaki disease is not in the disease itself. The disease itself is the acute traumatic disease and self-limited. But the problem in Kawasaki disease is in the complication and its effect on the heart and on the coronary artery. The same as the rheumatic fever. The problem in rheumatic fever is not in rheumatic fever. Rheumatic fever is self-limited and will improve by itself. The problem in rheumatic fever is in its complication on the endocardium of the heart and the valves of the heart. So this is why our lecture today about Kawasaki disease. Cause and epidemiology. The cause of Kawasaki disease is called also mucocutaneous lymph node syndrome. Mucocutaneous lymph node syndrome because it affects mucocutaneous and affect cervical lymph nodes. So they collect this in one word and call that mucocutaneous lymph node syndrome or Kawasaki disease. The cause of Kawasaki disease is not known, but it's like also rheumatic fever. They suspect it is immunological reaction after infectious disease. For Asian, it occurs more in Asian, especially Japanese, and the name Kawasaki from the one who discovered disease and called Kawasaki. Male to female 1.5 to 1. It affects predominantly small children. Kawasaki disease is disease of children below 5 years of age. 80% of the pediatric patients with Kawasaki disease are below 4 years of age, and 50% are below 2 years of age. So 50% of the patients with Kawasaki are in the age between 3 months and 2 years, and 80%, most of the patients of Kawasaki are younger than 4 years, but older than 3 months. So patients below 3 months are rare to be Kawasaki, and patients above 8 years are rare to be Kawasaki. Most of Kawasaki are between 3 months and 5 years. Around 4 years, 2 to 4 years is the typical age for Kawasaki. Kawasaki can be recurrent. The rate of recurrence. The rate of recurrence of Kawasaki is 3% in the same baby, and if one sibling have Kawasaki, the other sibling has the risk of Kawasaki 10-fold higher normal patient. Coronary artery aneurysm occurs in around 5% of patients with Kawasaki. It affects predominantly young children. Coronary artery aneurysm affects around 5% of the patients of Kawasaki, but coronary disease in patients of Kawasaki, if not treated, around 15 to 25%. So it is big ratio. So if patient is sure Kawasaki and not treated by IVIG, not early treated by IVIG, the incidence of having coronary artery disease is not low incidence. It is about 15 to 25% of these patients will have coronary artery disease. The pathology. Disease of Kawasaki causes what's known as microvasculitis or vasculitis of the medium-sized arterioles. So if you remember in the college, we take Kawasaki disease into 2 chapters. In the cardiac chapters for the coronary abnormalities and the rheumatology chapter as one of the microvasculitis. So Kawasaki disease is a disease of microvasculitis. So it doesn't affect only the coronaries, but also affect other medium-sized arteries like iliac artery, femoral artery, axillary artery, renal artery. But why we don't talk a lot about these arteries? Because coronary artery is most common to be affected, and coronary artery is the most dangerous to be affected. So we always talk about the most common and most dangerous. Like patient with Williams syndrome. Patient with Williams syndrome have what's called aortopathy, arteriopathy. He has problem of stenosis and calcification in different arteries. So he may have stenosis in the aorta, in the pulmonary arteries, in the renal arteries, in the brain arteries. But why it's common when we see patient William, we all think about supravalvular aortic stenosis and supravalvular pulmonary stenosis because it is the most common and the most dangerous. The same here in Kawasaki. Kawasaki is disease which cause, as pathology, cause generalized microvasculitis, which may affect lots of arteries, but the most dangerous is the coronary artery. So it's about the lecture today is about coronary artery. Coronary artery aneurysm develops in, as we said before, 15 to 20% of the patient during the acute phase and persists for 1 to 3 weeks. It may have several shapes. It may be fusiform, saccular, cylindrical, beads like grape. Okay, so the aneurysm of Kawasaki, if we take a pathology or an echo, it has different shape. Does the in the cardiac wise, does the Kawasaki is a disease of coronaries only, or it may affect other parts of the heart? It may affect other parts of the heart. It can cause pancreatitis, like also rheumatic fever. So Kawasaki may be associated with heart block because it causes endocarditis, may cause myocarditis and make myocardial dysfunction, may cause pericarditis and make pericardial effusion, but it's not common. I have never seen except one patient, and I'll talk at the end of this lecture about him. But most of the patients with Kawasaki doesn't have impairment of the cardiac function or pericardial effusion. Most of them, if he has abnormality, he will have coronary abnormality. So cardiac dysfunction or pericardial effusion is not common with Kawasaki. It's common with what's called MESI, multiple systemic inflammatory disorder post-COVID, which is Kawasaki-like. So, and we'll make differential diagnosis between them at the end of this lecture, inshallah. So Kawasaki almost affects the coronary artery, and rarely it causes other pancreatitis symptoms like inflammation of the AV conduction, myocardium, and pericardium causing pericarditis or myocarditis. Late change after few days, 40 days or 2 months, if we have big aneurysm, this aneurysm may heal with fibrosis, and when it heals with fibrosis, it will make stenosis. And if it makes stenosis in the coronary artery, which is the supply of the heart, it will cause myocardial infarction. So late complications of this aneurysm may be myocardial infarction. Myocardial infarction, how it causes myocardial infarction? Because it causes dilatation, and this dilatation will heal. The aneurysm dilatation will heal. We heal with fibrosis. Fibrosis will make stenosis, and stenosis will make ischemia and myocardial infarction. Also, as we all know, that patient with Kawasaki has high platelets count. It may reach 1 million, right? So he has tendency for formation of coronary formation of thrombosis. Okay, and he has stenotic part. He may have stenotic part in the coronary. So if he has stenotic part in the coronary with high platelet count, the incidence for formation of thrombosis in the coronary is very high. This is another reason of myocardial infarction in patients with coronary artery aneurysm. Coronary artery aneurysm may be coronary dilatation, may be only mild dilatation, and may be what's called aneurysm, large saccular aneurysm, which affects the dilatation is only inflammation, but aneurysm, it will affect all layers of the coronary vessel, like intima, media, and elastica. And it may have, as we said before, many shapes. It could be cylindrical, fusiform, or another shapes. We call it giant aneurysm if it is more than 8 millimeter, or in this core more than 10. So if in echo we measure the aneurysm, it is more than 8 millimeter, or by Z score it is more than 10 Z score, it is called giant aneurysm. It has poor prognosis for sure. This is the scheme of the pathology of the coronary arteries in Kawasaki. This is a normal coronary artery. It may only be dilated, and most of coronaries with mild dilatation will improve spontaneously, or it may have what's called aneurysm, severe dilatation. Aneurysm may be complicated with even, it may be also improved by time, or may be healed by fibrosis and cause stenosis, and then cause thrombus formation. So coronary artery may still normal. Maybe in patient not all patients with Kawasaki will have coronary artery disease. So some patients will have normal coronaries. Some patients will have mild dilatation, which will improve spontaneously. Some patients will have aneurysm, and this aneurysm will improve spontaneously. Some patients will have aneurysm, and the aneurysm will heal with fibrosis and cause stenosis and thrombus formation. This pathology of patient with Kawasaki, the red one, this red one is the vein. The vein is contain red blood cells, and the pink one is the artery, and as we see here, how it is occluded. The clinical manifestation of Kawasaki's disease passes into 3 stages. Acute stage, the first 10 days, subacute stage, the second 10 days, and convalescent stage. The most important stage, and the stage which we'll talk in details and in depth, is the acute stage, because the criteria of Kawasaki depends on this acute stage, and diagnosis of Kawasaki depends on this acute stage, and the most benefit of IVIG is in this acute stage. So acute stage is the stage of diagnosis and stage of treatment. The criteria, as we will say after that, of Kawasaki disease, so all the criteria will appear in the first 10 days. Okay, so the criteria of Kawasaki is in the first 10 days, and the most benefit, treatment of Kawasaki of IVIG will be in the first 10 days. Okay. Acute phase, the first 10 days, we'll talk about 4 subtitles in it. The first one, the 6 signs of Kawasaki disease. We all know all these 6 signs, which according to them, we say this patient may be Kawasaki, may be not Kawasaki, or may be atypical Kawasaki. Okay, so the criteria of Kawasaki the patient should have the first one, which is in a table alone, the fever plus 4 of the other 5 ones. Fever of Kawasaki typically should have sudden onset, should be very high grade fever above 3940, and should have poor response to antibiotic or antibiotic. So if fever and response to antibiotic and antibiotic, it is a sign that this patient is almost not Kawasaki. So the typical picture of the fever of Kawasaki disease is fever which have sudden onset, which have high grade fever above 3940. Low grade fever cannot be Kawasaki. I can say I have a patient with Kawasaki with 38 or 38.5 for 10 days. It's almost not Kawasaki. So to be typical Kawasaki, it should be sudden onset, very high grade fever, and with poor response to antibiotic and antibiotics. Then we will take the patient from above to downward. So we take fever, his head, okay, then his eyes, he had conjunctivitis. Conjunctivitis, it should be bilateral, non-purulent, okay? Because if the conjunctivitis is purulent with pus, it's almost bacterial infection. So conjunctivitis of Kawasaki bilateral, non-purulent, after the eye will go down to the mouth, oral change, will have cracked lips and erythema of the lips with strawberry tongue without pus. Okay, so we would differ it from scarlet fever and beta streptococcal infection. If we have streptococcal infection or drug reaction, almost will have focus, will have pus. But in this patient, Kawasaki will have cracked lips, erythema of lips, and strawberry tongue we leave them out and go down to the neck. We have cervical lymphadenopathy. The typical picture of cervical lymphadenopathy, it is always unilateral in the upper cervical, non-suburative, big, above more than 1.5, non-tender. So it's non-tender, non-suburative, unilateral, more than 1.5 centimeter. We go down to the body, the chest, and the groin. The patient will have rash. It starts in the first few days, and all of subsides during the first 5 to 7 days. So in the history of Kawasaki, most of the patients with Kawasaki, if the patient, most of the patients suspected Kawasaki will come to us after day 5, right? Why we suspect he is Kawasaki and we admit him? Almost he should have the first criteria for it, and we will search for Kawasaki after that. So most of the patients will be in day 7, day 8. So most of the rash of this patient mostly will take by history, because most of the rash in the Kawasaki patient appears in the first few days and disappear in the first week. So if he comes after 1 week, mostly will not found this rash. The rash is almost in the groin area or perineal area. It's the most crowded area with the rash of Kawasaki. Then to the extremities. Extremities appear first in the acute phase as edema and erythema, and in the end of the acute phase and at the other phases, it will be peeling. Will appear the peeling, which is a sign with desquamation and peeling, which suggests Kawasaki. So this is the 6 signs of Kawasaki. Fever, as we said before, fever should have sudden onset with high grade fever, doesn't respond to antibiotic and antipyretic. All of fever respond to IVIG على النقيض يعني. It should respond to IVIG within 36 to 48 hours. If fever doesn't respond to IVIG into 36 to 48 hours, either this patient was not Kawasaki or what we call after that IVIG resistant Kawasaki. It will have certain protocol according to American Heart Association. Okay, so typically Kawasaki patient respond to IVIG within the first 24 to 48 hours. If he passes 36 to 48 hours without response to IVIG, it could be IVIG resistant Kawasaki, like corticosteroid resistant nephrotic, and they have the same protocol near to each other. Okay. The other manifestations, conjunctivitis. Conjunctivitis, as we said before, there is no exudate, and that will help us to differentiate from others like measles and Stephen Johnson. And it resolves rapidly. Oral changes, erythema, dryness, crackling, strawberry tongue, cervical lymphadenopathy. Took care in about 50 patients with 50% of the patient. It's firm swelling, unilateral, mostly in the anterior cervical triangle, and it is more than 1.5 centimeter in diameter. Rash, as we said before, rash, it appears early and disappears early. It appears in the first few days and disappears within the first 5 days to 1 week. So mostly patients with Kawasaki rash, it will be just a history for us. Okay. Extremities starts as edema and edema and erythema, and after 2 to 3 weeks, we'll see desquamation of the hands and fingers. This is the clinical picture of Kawasaki. Rash, conjunctivitis, strawberry tongue, peeling of the fingers, and this edema of the finger and cervical lymph node, and this dilated coronis. And as we said before in the pathology, it is a microvasculitis. It could make dilatation in any other arterioles, not coronary only. So we talk about the first thing in the acute stage. It is the 6 signs, which according to them, we have the criteria of Kawasaki. Second thing in the same stage, the most important thing, and why me as a cardiologist is talking about Kawasaki today, because of the cardiovascular abnormalities. In the first slide, we said that Kawasaki is a self-limited disease, but the problem in Kawasaki, like rheumatic fever, the problem in Kawasaki is in its complication, not in the disease itself. It's in its involvement and complication to the heart, not in the Kawasaki disease itself. Okay, so cardiovascular disease, it may cause tachycardia, elevated dysfunction, pericardial effusion, should be common. And the most common is coronary artery abnormality. So when we do echo for patient with Kawasaki, we search for all of this. We search for the function. We search and we should comment for all of this. We should comment about the function, about pericardial effusion, pericarditis, signs of pericarditis, pericardial effusion. Valves are fine. Function is good, but the most important thing to comment is the coronary arteries. Coronary arteries always not affected in the first stage, in the first week or in the first 10 days. So if I do echo for the patient who has fever of unknown origin for about 6, 7, 8 days, and I found coronary arteries are fine, this is not a sign that the patient will have good coronaries and we will not have complication. Most of the complications in the coronaries appear in the second stage, not in the acute stage. But we could have signs in echo which suggests that this patient may have coronary complication later on, like slight dilatation of the coronaries, but not with the criteria, which we'll say after that. The criteria of dilatation of coronary artery in Kawasaki should be one artery more than 3 Z4 or more than 2 arteries more than 2.5 Z4. So may I find patient with mild dilatation but not with the criteria of Kawasaki, or may we have some echogenicity in the borders of the coronary arteries. It could be a sign of early inflammation of the coronaries, but still the coronaries not dilated or perivascular echogenicity. It may be a sign of that the patient will have inflammation but not dilated coronary arteries. Third thing, in the acute phase recurrence, we talk about 6 signs. We talk about the cardiovascular, and as we said before, there's a disease, multi-systemic disease, microvasculitis. So it may cause musculoskeletal system. So patient with, if I found, why we said that if a patient came suspected Kawasaki with signs of Kawasaki and he has arthritis or arthralgia, I can say, oh no, it's not Kawasaki. There's no arthralgia with Kawasaki. It may be another disease. No. Kawasaki, 30% of patients with Kawasaki may come with musculoskeletal system disorder, may come with arthralgia or arthritis. So if we found patient in the acute phase recurrence in the first 10 days and he has arthralgia, this doesn't exclude Kawasaki, it may support Kawasaki. So we should always remember that Kawasaki is a disease of rheumatic disease in the rheumatology chapter with microvasculitis, which may affect more than one organ. The most dangerous and the one to always focus on is the cardiovascular, but it may cause arthritis, arthralgia, may cause GIT symptoms, but it is rare. This note is very important because we'll make a table of differential diagnosis between Kawasaki and Messi in the end of this lecture. In multiple systemic inflammatory disorders, post-COVID, GIT symptoms is very common, About 60% to 70% of patients post-COVID with multiple systemic disorder will have GIT symptoms. In Kawasaki, it's rare, it's around 20% only. Kawasaki, we have trialburia. It's in more than 60 to 70% of patients who have Kawasaki. And this is very important note because it is one of the criteria of atypical Kawasaki. When the patient will not have this typical picture of Kawasaki, trialburia may help us to diagnose atypical Kawasaki. He may have also CNS manifestation. So the patient has fever and lethargy and irritability. This doesn't exclude Kawasaki. It could be Kawasaki also. The last thing in the acute phase, stage is the lapse of the acute stage. The patient of Kawasaki will have marked leukocytosis. He will not have leukopenia or lymphocyte predominance. Uh, what's the most common differential diagnosis of Kawasaki? Viral infection. Patient begin with prolonged fever and rash. He is even either he is either Kawasaki or viral infection. This is the first differential diagnosis, right? So in CBC, Kawasaki will have the patient will have marked leukocytosis, but in viral infection he will have leukopenia and lymphocyte predominance. Acute vessel reactance (CRP) will be high in Kawasaki. In viral infection, it will not be high. We can use CRB in follow up the prognosis of Kawasaki and its response to IVIG, but we cannot use ESR because ESR elevated by IVIG. Okay? So if patient has Kawasaki and has high ESR, and we give him IVIG, and we now want to know that the patient becomes better or not clinically and by labs. So we shouldn't repeat ESR to see if it is decreased or not, because ESR itself may increase by IVIG itself. Okay? Thrombocytosis in Kawasaki usually more than 450, and it may reach 700 and 1 million. But in viral infection, patients will have low platelets, and it is another differentiation between Kawasaki and viral infection. Biuria, as we said before, more than 60 to 70% of patients with Kawasaki will have biuria, will have elevated liver enzymes, more than twice normal, may have elevated cardiac troponin if the myocardial tissue is affected, and they have lipid abnormalities. HDL will be high, and total cholesterol will be normal, and triglyceride will be high. Echo, the last thing, in the first 10 days, coronary artery aneurysm or coronary artery changes is not common in this acute stage. Almost the coronary artery changes will appear, if there is coronary artery changes, will appear in the second or third stage, not in the first stage. So why we do echo for the patient, as we would say after that in the guidelines of American Heart Association 2017, they recommend doing echo at admission and after 1 to 2 weeks, and after 3 to 6 weeks if the patient has no aneurysm or normal coronary. Why we do echo at admission if patient before 10 days almost will not found coronary aneurysm or dilatation in echo? For many reasons. First, as we said 2 slides before, we may see signs which suggest that patient has some inflammation. It's not diagnostic signs, but it's suggestive signs that he has dilatation and he may have aneurysm or dilatation or thrombosis after that, like perivascular brightness or oxygenicity and mild dilatation. The second most important thing to search in this period is to search for others like LV dysfunction, pericardial effusion, mitral bifurcation. برغم انه قليل, it is rare, but it may occur and it is dangerous. So if a patient with LV systolic function, we should diagnose him early. Kawasaki causes dilatation of the proximal part of the coronary arteries. It usually causes dilatation in certain parts in each artery. It will it is better to be known by pediatric cardiologists who will do the echo. It's not important information, but in the left coronary artery, it will be before the bifurcation of the left main coronary artery to lead and circumflex, and right coronary artery after the twist. The right coronary artery starts with like twist and then becomes straight. It will be in this straight area. We'll say that the patient has coronary artery dilatation. We should take measurements of every branch of the coronary, the left main coronary artery, lead, left anterior descending, left circumflex, and right coronary artery, and put it on this score according to body surface area, weight, and height. If one artery has dilatation or aneurysm in a part of it more than 3 this score, or two arteries more than 2.5 this score, it is considered Kawasaki. This is a picture of patient with right coronary artery Kawasaki. This is called short axis parasternal view. This is aorta, main pulmonary artery, RV, and this right atrium. Here is the right coronary artery. In echo, right coronary artery is like flame. It's like it's seen very thin, and left coronary artery also it's seen very thin. We shouldn't see it like a ball like that. So it is right coronary artery aneurysm. Aneurysm may be, as we said before, saccular, fusiform, or taking cylindrical, may take different shapes. And if it is more than 8 millimeter or 10 this score, we call it giant aneurysm. So we finished the acute phase. We said acute phase, we have six criteria of Kawasaki: cardiovascular signs, echo, other systems, and labs. Subacute phase and convalescent phase. These phases doesn't enter in the diagnosis of Kawasaki. Okay, so why we need to know it? We need to know these phases for two reasons. First reason, it may confirm the already diagnosed Kawasaki. Okay, so if I diagnose patient as a Kawasaki, but I'm not sure, but I suspect I have high suspicion as Kawasaki, and I start IVIG. Okay, when the patient has 8 or 9 days fever. Now the patient is at day 11, 12, 13, and I started to appear desquamation and peeling of the tips of the toes. We do echo and found coronary affection. Some platelets become 700,000 or 1 million. So, oh, yeah, this patient really was Kawasaki. So, subacute phase may confirm the already diagnosed Kawasaki. It's not in the criteria of diagnosis of Kawasaki, but maybe in subacute phase when I found signs like desquamation or any coronary affection or very high platelets, because platelets become very, very high, about 700 million or million in the subacute phase, not in the acute phase. Okay? It increases gradually to be the most high platelets in this phase, which is subacute phase. So if I found one of these signs, I'd say yes, it was Kawasaki. What's the convulsive phase? Convulsive phase is the phase till the labs becomes normal. We said in Kawasaki there is very high ESR, very high platelet. Till these labs return to normal, it is called convulsive phase, like recovery phase. You can call it recovery phase or convulsive phase. So this is the clinical picture of Kawasaki. How we diagnose Kawasaki? As we said in the first slide in the clinical picture, Kawasaki disease, to be diagnosed, we have fever of 5 days plus 4 of the 5 major criteria, which were conjunctivitis, oral manifestation, cervical manifestation, rash, and extremities. We should have at least 4 of these 5. As early as I suspect Kawasaki, we should start IVIG, because as early as IVIG is started, it can reduce damage of the coronary arteries. Like in rheumatic fever, as early as we started the prophylactic antibiotic, we can prevent the effect on the valvular disease, the valves. Here, as early as we started IVIG, the risk for coronary arteries effect is decreased. But unfortunately, not all patients come with typical Kawasaki picture, and not all patients, Kawasaki patient came with fever plus at least 4 of these 5 criteria of Kawasaki. So appear the term of incomplete or atypical Kawasaki, because as we said before, Kawasaki disease is self-limited disease, but its effects on the chronics are very harmful. So we need to not to miss any Kawasaki disease. So atypical Kawasaki or incomplete Kawasaki term was put to not to lose any or miss any patient suspected Kawasaki disease. This is a very important scheme in the American Heart Association 2017 for diagnosis of incomplete Kawasaki disease. Who are the patients whom we can call incomplete Kawasaki disease? Is the patient with more fever, more than 5 days, and 2 or 3 compatible clinical criteria. We said typical Kawasaki is fever more than 5 days and at least 4 compatible clinical criteria. If the patient has fever more than 5 days and only 2 or 3 of the compatible clinical criteria, or if the patient has fever more than 7 days and he has no focus, patient has prolonged fever, 8 days, 9 days, 11 days, but he has no focus. I cannot diagnose him. I make investigations and something like that, and we have no certain diagnosis. Those patients are called atypical Kawasaki or suspected Kawasaki. So atypical Kawasaki or incomplete Kawasaki is patient with fever more than 5 days with 2 or 3 compatible clinical criteria, or patient with only prolonged fever with no focus. First of all, we do acute phase reactants for him, CRP and ESR. If CRP is below 3 and ESR below 3 milligram per deciliter and ESR below 40, okay, so this patient is most probably not Kawasaki. We'll complete our clinical and laboratory evaluation and see how the patient is suspected. Here is a very important question for me because of echo. If the patient has fever more than 5 days and I suspected he is in complete Kawasaki and we do ESR and CRP and it is low, okay, shall we do echo for him or not? No, we shall not do echo for him unless he has peeling of his hands, he has desquamation of the hands, okay? Because if we do echo for him, so we'll do echo for any patient with prolonged fever, right? Even with low acute phase reactants. So if the patient has low acute phase reactants, low CRP and ESR, we'll evaluate the patient clinically and with labs without echo, إلا لو if he has typical peeling. If he has typical peeling, we'll do echo for him. If the patient has CRP more than 3 and ESR more than 40, high acute phase reactants, so he is suspected to be atypical Kawasaki, we'll do another lab. So we'll do CBC, liver function, and urine analysis, okay? And echo for sure. We'll do CBC, liver function, urine analysis, and echo. If echo is positive alone, with less coronary dilatation, okay, this patient is sure atypical Kawasaki and will start treatment, okay? What about the labs? If we have 3 of these 6 labs, the patient is typical Kawasaki. If he has anemia for age, if he has platelet count more than 450, that albumin low than 3, elevated ALT, white blood cells more than 45, or biuria, sterile biuria, urine, white blood cells in urine more than 10. If he has 3 of these 6, he is atypical Kawasaki and we should start IVIG. Okay, again, because this one is one of the most important slides in this lecture, the patient who has no typical features of Kawasaki, like he has fever more than 5 days with 2 or 3 compatible clinical criteria only, not 4, or he has prolonged fever with no focus. We'll do first acute phase reactant, CRP and ESR. If they are low, he is mostly not Kawasaki. We'll make further clinical and laboratory evaluation, plus or minus echo. If he has peeling, we'll do echo. If no peeling, no echo. If the patient has high acute phase reactants, we'll do some labs and echo. If echo positive, okay, we'll start immediately IVIG. If 3 of these 6 labs is positive, we start IVIG. Labs are CBC, liver function, and urine analysis. If the patient has anemia or platelet more than 450 or white blood cells more than 15 or albumin less than 3 or elevated ALT or urine up more than 10 white blood cells, he is a typical Kawasaki. As we said before, we should differentiate Kawasaki from bacterial infection. We'll find focus, pus focus, or viral infection. And as we said before, we can by lab suspect it's not viral and it's Kawasaki. Before starting talk of the how to treat Kawasaki, we should first know what's the natural history of Kawasaki. Natural history in cardio, in all diseases of cardio, we have what's called natural history. Natural history means what if I leave this patient without treatment, how he will be, and what will if I give this patient treatment, how he will be. That's what's called natural history. And we have in all diseases of pediatric cardiology, we have a title called Natural History of this disease and Congenital Disease. Pulmonary stenosis, what if I leave this patient and what if I treat this patient like that. So natural history of Kawasaki disease, as we said before, it is self-limited disease, but it may affect the heart and cause cardiovascular involvement. Coronary aneurysm occurs in 15 to 25% of untreated patients with Kawasaki. Okay, the risk for coronary disease increase with the increase of the temperature and the duration of the temperature. So as the temperature increase, yani patient with fever 41 is more risky than 40, more risky than 39. As the temperature increase, the risk increase. And as the duration of fever increase, the risk for coronary aneurysm increase. So patient with fever more than 14 days, not like patient with fever more than 7 days, and so on. Most of the aneurysm improves in the first 1 to 2 years, but here it's very, very important point. The aneurysm healed in echo, okay, and maybe healed in CAS, but the arteries doesn't have the capability to dilate in response to exercise or coronary vasodilation. For myself, I suspect that it may be one of the most causes of youth death with cardiac arrest in the last 1 to 2 years. I myself know lots of people around me and 20, 30 years old and have cardiac arrest, and we don't know why. I myself, I think it is because of COVID, even COVID itself or COVID vaccine. Okay, it may cause like what Kawasaki caused. It cause resolving of the aneurysm. So if the patient do echo or do angiography, it will be fine. But the artist doesn't have the capability to dilate in response to exercise. So if this patient with exercise or with stress, when he's a player, like one Egyptian player died last week, when he played and under stress of match, the artist hasn't the capability to dilate, so the patient will arrest. So angiographic resolution for aneurysm 1 to 2 years after illness occurs in 50 to 67% of the patient, but the artist, the patient who has big aneurysm which resolves, doesn't have the capability to dilate in response to exercise or coronary vasodilators in CAS, or it is tests which can be done in CAS. Okay? More than 70% of myocardial infarction occurs in the first year after onset of disease. Okay? If the patient has giant aneurysm and has thrombosis or stenosis, and he is at risk of myocardial infarction, 70% occurs in the first year and occurs suddenly. Okay, and this is the benefit of long-term follow-up of the patient who have dilated coronaries, because myocardial infarction occurs early in the first year and occurs suddenly. So we should suspect that before losing this patient. So as we will tell at the end of the treatment, in long-term treatment, patient with dilated and coronaries or thrombus or stenosis in the coronaries, we should have regular close follow-ups and may have advanced follow-ups like stress exercise test and angiography and cardiac CT or something like that. Okay, so if a patient has giant aneurysm and have thrombosis and have stenosis, the risk of myocardial infarction will occur in 70% of this patient, and it occurs suddenly. Also, in the treatment, it is it's beneficial to diagnose these patients early, so he could have the chance to take streptolysin or streptolytic medication to light this thrombus. If the coronary artery remains normal through the first months, usually it will still normal. So as you all know, and as we do in our hospital, patient if he has normal coronary, we will do follow-up echo after 2 weeks, 2 to 3 weeks, and follow-up echo after 6 weeks. If both follow-up echoes are normal, so we don't need to do another follow-up echo, because usually if the coronary artery remain normal first month, it will keep normal for life. We may give him for confirmation another echo after 1 year or not. But if he has all echoes normal in the first month, usually it will remain normal. Management, I think we can divide the management into 4 topics: initial management, management of special situation, prevention and treatment of coronary thrombosis, long-term follow-up. Okay, so we'll talk about initial management, management of special situation, prevention and treatment of coronary thrombosis, long-term follow-up. Initial management, as we all know, the drug of choice and the only drug for Kawasaki is IVIG. It's given as single infusion. The single infusion gives slowly in 10 to 12 hours. Okay. The best time to give IVIG is in the first week, first 7 days, or maximally as first 10 days in the acute phase is the best time to give IVIG. It's not good to give IVIG after the 10 days, because almost after the 10 days, if there is coronary abnormality, it will occur. Okay. After IVIG infusion, 2/3 of patients will become afebrile in the first 24 hours, but most of the patients in the first 48 hours should be afebrile. If the patient passed his first 48 hours and he's still febrile, even he's not Kawasaki, he is measles or varicella or something like that, or he is IVIG resistant Kawasaki. So when we give IVIG to patients suspected Kawasaki, he should be afebrile in the first 24 to 48 hours maximally. If he's still febrile, he is even not Kawasaki, wrong diagnosis, or he is IVIG resistant Kawasaki. Okay. Here's this very important thing. IVIG and dose is not related to echo. Absolutely not related to echo. So if I suspect the patient is Kawasaki, I will give him IVIG. If echo is normal, I give him IVIG. IVIG is for treatment of Kawasaki. Either coronaries are normal or abnormal. Okay, so we don't wait for echo to give this patient IVIG. Okay, and if the echo is fine, he will complete the IVIG dose. He will not stop it. Okay, IVIG for inflammation in Kawasaki. The other thing to be given with IVIG is high dose aspirin. According to American Heart Association, patients should take aspirin in a high dose, 80 to 100, or medium dose every 6 hours, and he should complete continuing on this dose after fever resolved by 48 to 72 hours. Most of us stop anti-inflammatory dose as long as fever resolved. we should complete on aspirin on anti-inflammatory dose after fever resolved by 48 to 72 hours, and then shift to antiplatelet dose, which is 3 to 5 milligram per kilogram per day, and continue on it for at least 6 to 8 weeks. برضو بغض النظر there is coronary affection or not, because the patient is Kawasaki, so we're complete on antiplatelet dose for 6 to 8 weeks, even there is coronary evidence or not. But if there is coronary evidence, we'll make more regular follow-up of echo. يعني if patient is normal, okay, let's say this patient is normal now, he will start IVIG and anti-inflammatory dose of aspirin. After fever resolved by 48 to 72 hours, we'll shift aspirin to antiplatelet dose 3 to 5 milligram per kg per day, and we'll continue it for it to 6 to 8 weeks. For echo, we'll follow up the patient after 1 to 2 weeks, okay? And another follow-up after 6 to 8 weeks. But if the patient have aneurysm or significant coronary dilatation, we'll make earlier follow-up and more frequent follow-up. We may make follow-up twice a week. This is according to American Heart Association also, 2017. You will have twice echo a week, then once a week. Okay, so the routine echo, which is after 2 weeks and 6 weeks, is for normal patients. But if the patient have abnormalities in the coronaries, according to the abnormalities, will be the frequency of the echo. It may be up to twice weekly. Okay. In Japan and Western Europe, some countries start antiplatelet dose from the first. They give antiplatelet dose aspirin with the IVIG. Their idea is that first, I don't need the anti-inflammatory dose of aspirin because I give IVIG, which is anti-inflammatory, but I may need the antiplatelet dose from the first to prevent thrombosis. The second concept for this, to avoid Ray's syndrome, because I'm not very sure that this patient is viral infection. Although we have the differential diagnosis between Kawasaki and viral infection to avoid Ray's syndrome. But the most common protocol, which most of countries and centers go on it, is to have anti-inflammatory dose, and after fever resolved, to shift to anti-platelet dose. Other anti-inflammatory dose, we'll talk in detail after that. In the patient who are IVIG resistant, we may use corticosteroid, aximab, infliximab, or cyclosporin or others. So we talk now about first. We said the management of Kawasaki disease will divide it into 4 topics. First, initial treatment, then special situation, then coronary prevention and treatment of coronary thrombosis, then the last is long-term follow-up. Now, special situation. If patient came for me with fever 12 days, 13 days, 14 days, okay? Shall I give him IVIG or not? We said a lot in this lecture that IVIG is typically used in the first week or first 10 days. After first 10 days, may not have the most benefit of it. So if patient came to the hospital, came to Sahara Hospital, and he has been feverish for 12, 13 days, should I start IVIG or not? Okay, this is the first question. The second question. If patient, I give him IVIG and the fever is solved, and after 2 to 3 days, he becomes feverish again, what's called recurrent Kawasaki disease. Should I give him IVIG again or not? So he's not responding to IVIG his first time and he has recurrence. Should I give him IVIG again or not? Okay. So the answer of the first question, if patient came after 10 days, should I give him IVIG or not? I should give him IVIG in 2 conditions. The first condition, if he is still feverish, and patient came at day 12, 13, 14, but he is still febrile, so I give him IVIG. But if he is afebrile, I not give him IVIG. Or if he came and we do echo for him and he has coronary abnormalities, so I give him IVIG to stop the systemic inflammation and to decrease the progression of certain inflammation and to decrease the effect of the chronic. So if patient came after 10 days, I give him IVIG into two situations. The first, if he is still febrile, he came after 20, 13, 14 days and he's still febrile, or if we do echo for him and he has coronary abnormalities. For recurrent Kawasaki disease, should I give him IVIG? Yes, I will give him IVIG again. Another special situation is what we call IVIG resistant Kawasaki disease. The patient who takes IVIG and not respond to it, and he is still febrile after IVIG by 36 to 48 hours, and I'm sure he's Kawasaki. Okay, doesn't disturb me in my diagnosis and said he may be measles or something like that. He's still by criteria clinical and labs, he is Kawasaki. So I suspect he is not viral infection. I still suspect he's not viral infection, but he is IVIG resistant Kawasaki disease. What shall I give him? The first drug choice to give him a second dose of IVIG. Okay. With this second dose, we can give alternative medication because the first dose doesn't respond to the first dose, so we can give him second dose IVIG alone, or we can give him second dose IVIG with alternative medication. Alternative medication may be high dose pulse steroids, methylprednisolone, 20 to 30 milligram per kg, or longer tapering course of prednisolone over 2 to 3 weeks. If we give him high dose pulse steroid methylprednisolone, we give him for only 3 days. But if we give him prednisolone, we'll give him over 2 to 3 weeks, and we taper it gradually. We can give him infliximab also, 5 milligram per kg. If he doesn't respond to IVIG with one of these alternative, even high dose pulse steroids or prednisolone or infliximab, one of them, okay, we can start cyclosporin. If he doesn't respond to cyclosporin, the last thing is immunomodulatory monoclonal antibody therapy. The third thing is the treatment management of Kawasaki is prevention and treatment of coronary thrombosis. How to prevent formation of thrombus and what to do if it is already formed. How to prevent formation of thrombus? If the patient is normal, we will start low dose acetylsalicylic acid, aspirin, 3 to 5 milligram per kg per day for 4 to 6 weeks. This will decrease the incidence and prevent the formation of thrombus. But if the patient has coronary aneurysm and this score more than 10, we'll give also, besides the aspirin anticoagulant, so we'll give him aspirin and warfarin. If the patient has giant thrombus and has history of coronary artery thrombus, we'll give him 3 antithrombotic. We'll give him aspirin, Plavix, and anticoagulant. So if a patient normal, aspirin only for 4 to 6 weeks. If he has giant aneurysm, he will take aspirin and warfarin. If he has giant aneurysm and history of thrombus, we'll give him a triple therapy, giant aspirin, Plavix, and warfarin. What if thrombus were already formed? If it is early thrombus, it is acute thrombus, we can give him thrombolytic therapy, and it is one of the benefits of doing regular follow-up echo for patient with big aneurysm or giant aneurysm was susceptible to have thrombus. So if we diagnose this thrombus early, we'll give him thrombolytic streptolysin thrombolytic therapy. But if it is late thrombus, we'll give him aspirin and heparin. Okay. Because if it is canalized, and thrombolytic therapy will not have benefit, as we all know. Long-term follow-up. Long-term follow-up depends on the situation of the coronaries. Okay? If the patient have no coronary affection, or he had transient coronary affection, has coronary affection and mild coronary affection, and it is resolved. So we will give him aspirin till 6 to 8 weeks, and follow up echo till 6 to 8 weeks also. So he will continue on aspirin for 6 to 8 weeks. During this 6 to 8 weeks, we'll do for him 2 follow-ups, one at 2 to 3 weeks and one at 6 to 8 weeks. And we have done the first one upon admission. So we have upon admission 2 to 3 weeks and 6 to 8 weeks. If the patient have coronary aneurysm, he will have low dose aspirin and warfarin. If he has giant aneurysm, this patient may need advanced facilities for follow-up, like stress exercise test, and may have CAS or cardiac CT. This is a table in American Heart Association, divides the patient according to the coronary affection, no affection, mild coronary aneurysm, coronary aneurysmus, thrombus, and every patient how to follow up him. This scheme for management of patient with prolonged fever and suspected Kawasaki. So if patient came with fever less than 5 days, we'll start antibiotic if suspected bacterial infection. If the fever persists for more than 5 days, so it is suspected to be Kawasaki. We'll see criteria. If the criteria goes with Kawasaki, we'll start IVIG. If criteria goes with incomplete Kawasaki, we'll also start IVIG. When to do echo, this is very important to me. We do echo at the upon admission, okay? And as we said before, at 2 to 3 weeks and 4 to 6 weeks. But here I want to have rapid talk about what's called urgent echo. Urgent echo is the echo that affects the management of the patient, okay? So echo at upon admission for Kawasaki is not urgent echo because it will not affect the management. Either echo is normal or abnormal, will give him IVIG, right? So it can be done after 24 hours or 48 hours, but it should be done upon admission at the first 24 hours of admission, okay? But it will not affect the protocol of management of the patient. When the patient should have urgent echo now in these hours, if he is symptomatic, if he is in heart failure, he has gallop, I suspect he has myocarditis or something like that, he should have urgent echo now. Or in every case, if he's not clear, and I'll depend on his Kawasaki or not on echo. If he has a coronary arteries, I'll suspect he's Kawasaki. If he has no problem with the coronary arteries, I'll say he's not Kawasaki. This is a two situation which we need to echo urgently. This is the guidelines which from American Heart Association. I can send you the paper. It's a big paper, around 58 papers or 59. The last thing, in 2 minutes, how to differentiate between what's called MISC versus Kawasaki disease. In 3 minutes, okay? The first time to hear about multiple inflammatory systemic disease post-COVID, it was in I was in Saudi Arabia in the COVID era in 2019, 2020, and I heard in 2020 I heard one of my colleagues, his pediatric hematology, and he said we have 2 patients with Messi. 2 patients Messi. Why Messi came to our hospital? What he do? And in Corona, he came to our hospital in Corona. And I know after that he said Messi. He meant by Messi multiple inflammatory systemic COVID, multiple inflammatory systemic disease post COVID. Okay, but it was not common at this time. Second time, I see this patient by myself. It was in Egypt after a few months of this situation, and one patient came for me suspected Kawasaki. Okay, and he has history, looks like Kawasaki, and we do echo for him to exclude abnormalities in synchronous. And this patient, I have never seen Kawasaki patient like this patient. He has severe pericardial effusion. The heart is like a fish in bag of water. It rolls in the severe pericardial effusion. The patient is in pericardial tamponade, severe cardiac dysfunction. I have never seen Kawasaki with this type of cardiac dysfunction. He has severe cardiac dysfunction, has severe aneurysm, severe big giant aneurysm. The coronary artery aneurysm was bigger than the aorta itself. Okay, I see two aortas, the aorta and another aorta beside it, and I found by by uh, by scanning echoes, by scanning several fluids, that it is coronary. I have never seen coronary like that. So I respond to them that the patient is severe Kawasaki, and he go to University Hospital there in Egypt, and they manage him as Kawasaki, because at this time there was no multiple inflammatory systemic disease post-COVID common in Egypt. And at this time, most of these patients are considered Kawasaki. And we said that we have lots of Kawasaki patients in Egypt. And we found after that, after papers are published about Messi, that they were not Kawasaki, they were multiple inflammatory systemic disease. And after 1 to 2 days, I read about MISC, and I called them, called the prof. I think he's not Kawasaki, he is MISC, and this patient was MISC. So, what's multiple inflammatory systemic disease post-COVID? It is first discovered in United Kingdom. They found that patients with history of COVID have one of two clinical pictures. Even clinical picture of looks like Kawasaki disease, or clinical picture looks like اللي هو اللي هو toxic shock syndrome. So it could be come with one of two clinical picture, even toxic shock syndrome or Kawasaki disease. The one which we need to differentiate now is Kawasaki disease. So the patient will have clinical picture like Kawasaki disease, and we will have Messi. So how to differentiate between multiple inflammatory systemic disease, post-COVID, and Kawasaki disease? First of all, MISC affects older children. Kawasaki disease affects younger children. MISC comes more with black children. Kawasaki comes more with Asian children. The third thing is very important. Gastrointestinal symptoms is very common, very common in MISC. It's one of the criteria of MISC. We may talk about this topic in another lecture, but it's rare in Kawasaki. Myocardial dysfunction is common, very common with MISC. It's rare in Kawasaki. Pericardial fusion is common in MISC. It's rare in Kawasaki. D-dimer, ferritin, CRB is very high in MISC. CRB high in Kawasaki, but not like in MISC. Platelets is low in MISC, but it's high in Kawasaki. Interleukin 6 is high in MISC. Okay. Coronaries is more affected and more aneurysmal, but the most thing which may make us suspect that this patient is MISC, not Kawasaki, is history. If the patient has history of Kawasaki disease in him or in the surrounding family, 15 to 20 days before the symptoms, so it could be MISC. So if the patient came, we can do it now. If the patient came with Kawasaki disease, we need to ask him in the history if he has himself, the patient, symptoms of COVID in the last 15 days or 20 days, or one of the family has symptoms of COVID. So we may suspect MISC, not Kawasaki disease. Okay, thank you. شكرا يا جماعة ونشوفكم في المحاضرات الجاية إن شاء الله. Thank you.
Hello.
Hello.
Ahmed. Anyway,
What's about?
good, extensive presentation. But anyway, main problem, we don't know the exact cause of the Kawasaki. It's some ethnic group has got a genetic predisposition. But one thing I want, because the fever character is remittent, that means spikes of fever in a day, but never reaching the baseline. This is the character of the fever we noticed. And you have clearly explained that incomplete Kawasaki, this is very important. We have to diagnose that part. And other thing is that suppose if you the diagnosis is very important. And one point I wanted to, most of the children, they will have erythema and edema of the palms and soles. This is very important also. You can diagnose a little early if one day before, if there is erythema and edema of the palms and soles. Am I right? Hello?
Right, sure, right. These are the criteria, the 6 criteria of Kawasaki. Thanks for addition about the fever, the criteria of fever, is that it doesn't return to the baseline. Right, all Kawasaki patients I have seen, the fever doesn't return to baseline. It's almost high and may decrease something, but it returns high, but never become normal.
Yeah. Other thing is that because the diagnosis is very important, because if you do not give IVIG, the chance of coronary aneurysm is approximately 25%. But if you give IVIG, the chance of aneurysm is reduced to 4%. So it's a market difference, isn't it?
Right, so it is a benefit of the lecture and the diagnosis of Kawasaki. Kawasaki is self-limited disease, but the benefit of diagnosis of early diagnosis for Kawasaki, if I left Kawasaki itself, it may resolve itself. But the most important of Kawasaki is to give IVIG early. As you said, if we give the patient IVIG early, the incidence of coronary effect may decrease to around 4%. If the patient lived without IVIG and he was really Kawasaki, the incidence of coronary abnormalities may be 20 to 25%. Yeah, 1/4 of the patient will have coronary abnormalities.
Yes, that is very important. That's why we need the early diagnosis and treatment.
Right.
That's
right. Right, Dr. Baba. Thank you.
Welcome.
Okay, thank you all. See you inshallah in the next lecture. We'll have 2 lectures per month. One will be pediatric cardiology and one will be other. So the next lecture will be other systems, inshallah.
One suggestion, Ahmed, you have very extensive talks. So suppose if you, because people cannot concentrate too much. So if you brief the things, it will be better. This is my suggestion only. You can do it, but make it little smaller so that all can concentrate more.
Okay, inshallah. Okay, we'll concentrate it or make it the lecture smaller and in less time, inshallah.
Yeah, thank you.
Okay, thank you. Okay, thank you all, inshallah.